All right. Good afternoon, everybody. Welcome to the Delaware ACCEL CTR Innovative Discovery Series. As many of you know, we extend continuing medical education credit for these talks. We'll distribute the information via email to those that registered for today's event. And if you didn't register prior to today's talk, you can still obtain CME by contacting Lisa Maturo at ChristianaCare. And Lisa, if you can just type in your email in the chat box, that would be great. Future talks coming up include a tech talk on July 8th by Dr. Bethany Wolf from the Medical University of South Carolina, and the talk is titled Illuminating the Black Box, Variable Importance for Interpretable Machine Learning. And then the next ID series talk will be on July 23rd by that very popular speaker, TBD. We'll let you know more about that later. But today, it's really my pleasure to introduce Dr. Christina Bethell. Dr. Bethell is professor at Johns Hopkins in the Bloomberg School of Public Health, where she's the founding director of the Child and Adolescent Health Measurement Initiative, TXCAHMI, in the Department of Population, Family, and Community Health. Christy received her MPH and MBA at the University of California, Berkeley, and her PhD in health policy research at the University of Chicago. She then was a senior investigator at the Kaiser Permanente Center for Health Research, and then was on faculty at the Oregon Health and Science University before coming to Hopkins. Dr. Bethell founded the Child and Adolescent Health Measurement Initiative, TXCAHMI, whose primary focus is to advance patient-centered health and healthcare quality measurement and improvement. TXCAHMI promotes this through child and family involvement in defining, assessing, and improving healthcare quality, and advancing consumer-centered data-driven policies and practices. He's the PI for the Data Resource Center for Child and Adolescent Health, which is a HRSA Maternal Child Health Bureau funded center that develops, designs, and disseminates large data sets such as the very popular National Survey of Children's Health and the National Survey of Children with Special Healthcare Needs. Dr. Bethell and her group developed a real user-friendly, interactive, web-based platform for researchers and citizen scientists to access and analyze data from these surveys. It's really an amazing example of a patient, family, and community-centered approach to health and healthcare data. Dr. Bethell, in and of herself, is an accomplished researcher in child health and health services. I can go on to discuss her work in areas such as childhood adversity, positive approaches to health constructs such as flourishing and thriving, mindfulness in child health, and patient resources such as the Well Visit Planner. But I want to give her some time to talk, so I'll stop here and turn the podium over to Dr. Bethell.
Thank you, Lee, and thank you to all who are there today that I can't see. I'm going to imagine that I am seeing you. I want to also acknowledge that is Juneteenth Day, at least here in Baltimore. And thank you for taking the time to be here today on this celebration day. And really, it's very pertinent to what I'm going to be talking about, which is talking about how do we translate, give you some information and resources on translating the science of child development into policy and practice, and the importance of family-centered, community-centered data and tools to make that a reality. So I'm going to go ahead, and this is who we are in terms of, we do a lot of data in action and measurement in action, because when I got started in my career, there was no data at all on even who are kids with special needs, what is developmental screening, how do we measure it, how do we know what we're trying to do, how do we know what we're doing. So it was really a wasteland in many ways, and I was so eager to help shape policy, but there wasn't data, and without data, we really can't create the arguments and test our hypotheses and bring them forward. So that's been really a life's work. So I'm super excited to be with people who are in their earlier career, if possible, who can now pick up the banner and start moving this into policy even further now that we have normed the measurement of things that we really know are critical to measure in order to inform and drive and track the impact of our policies and practices. So that's what we do. We advance transformative goals, try to discern and develop actionable data, inspire and inform using this data for transformational partnerships at every level, and then where the innovation and action can happen to try to achieve those goals and stay on the learning continuum continuously. So my work is very much a CQI kind of model, if you will. and that everything we do, either the way we do it or the goal for doing it, is about advancing family and community engagement. And so communication between families and providers, of course, to build trust is so critical. We know we have lack of uptake of the innovations that we do have available for families, and that trust and feeling safe and having those coherent, consistent relationships is so important. How do we do that? And how do we move that forward? Family involvement and shared decision making at all levels, in their care, in their even wellness care, and so on and so forth, and making that go beyond sort of the just informing families, but really actually engaging in powerful shared decision making. Active collaboration within organizations and systems. There's a lot of different work we've done on that. And then finally, to help engage families and communities on their own behalf to activate self, family, and community-led healing, which ultimately we can do a lot, but ultimately where we're trying to see shifts for the positive are in the home and in the community and in the culture. And so how do we engage people in their own care, in their own sort of will to be well, and learn when life can often be so hard. And so there's a lot to do on this engaging ourselves and each other and communities and families to proactively promote well-being, which is possible. So we started with the CAP survey. So anybody who knows about that, was the original work we did was the CAP survey for kids and kids with special needs, medical home, and you can see all these different measures. And so if you're out there doing measurement, you may look at little different pieces, like, is this happening? Is partner in decision making? Do they have a usual source? And it usually kind of looks like this, and it can be very misleading, because if you actually look at a person-centered profile of performance, which me as a person, as a family, I get all of that. So how many families felt like a partner and met medical home criteria and had adequate insurance? And when you do it that way, these are the kind of numbers we're talking about in the country for performance of our systems. And this is actually specific for children with special health care needs, which actually do a little bit better. Oops, sorry. I don't know how that happened. So I want to just say that how we think about data and measurement is very important when it's family-centered, because you peer through the eyes of a person that isn't split up into these little body parts, that isn't split up into these different aspects of quality. And we started with this person-centered model, like say for diabetes, where you don't just measure, did you get an HbA1c? Did you get a foot exam? Did you get an eye exam? But really, how many children, let's say, or adults with diabetes actually got all of those minimum core set? And it's very low. But if you look at every one, it can look higher. So how do we really shift to a person-centered and outcomes-based profile of performance, which I'm going to talk a lot more about. So I'm going to first talk a little bit about what do I mean by the science of flourishing, which is something I want to seed in case it's not already. And then I'm going to be sharing a lot of data that you can have access to. So everything I'm showing you is mostly based on the National Survey of Children's Health, so that you can get an illustration of what kind of information is there and some of the ways that you might want to use it if you want to. And we do provide data sets and code books in multiple languages, and I'm going to end with giving you ways to get access to that. I'm also going to be talking about some engagement tools, some family engagement tools that we've been researching and developing that we need research partners in. Also just the concept of engagement, a model of engagement, and starting to really engage everybody we can in a kind of national research. We have a community and family engagement research network that we're trying to build, and really to bring people in with various priority questions. And so I'd love to, if we ever had time, or after this call, if you want to email me, being interested in joining a network of people who are specifically looking at how can we be successful at community and family engagement. And then again, I will leave you with some resources on the measurement. So this is going to be a little bit of an odyssey, and on purpose in a way, because I won't be able to like sit on every single slide. That's not the point. You'll be able to see most of this after. There's a couple slides I have to remove because they're in press for some research, but other than that, you'll be able to see all of this again. And you know, if you're really interested, I'm happy to meet with those who are interested later as well to take a deeper dive. So I don't have anything to disclose. I already said some things, but I haven't gotten into the meat of it. But I do want to say that I remain very optimistic despite the difficulties we see in our society today. I tend to see it as it's just unearthing what's already been there. And that when you're actually in a chaos state of unearthing what's already been there, the trauma, the discord, the lack of distributing belonging equally, compassion. We don't really have a society that is mirroring what we say we want. And so it can create discord, but that's a good sign because we're revealing it. And so for me, that's really the path toward healing always ends up sort of starting with what's not going well. Like we want to heal, so now we have to do this sort of truth and reconciliation at every level, whether it's with me and you or systems level or community level. And so I am very optimistic, and also because the science shows that with bringing our intention to change and learning how to change, because we are change machines really when we develop, but we sort of get stuck in patterns and we forget how to change, and we forget that we're actually co-creating all these policies, and that when people come together, we can actually change, but we have to be willing to. So, and that doesn't happen unless we feel safe. And so the science of child development, talking about safe, stable, nurturing relationships, really pervades everything we do from there on to create and manifest well-being, because we have to change to do that. And if we don't feel safe with each other in systems or community collaborations to do that change work, we actually won't be able to implement the science of child development, which is about creating safe, stable, nurturing relationships in many ways, and the social structures and policies to support that. So it's an irony, but I think the fact that we know we are not stuck, we can grow and change, that from epigenetics, we know that so much of what gets turned on and off is based on experience, and that's emotional experience and how we take things in, not necessarily whether you think I should have been hurt or not by something, but whether it really happened in my own physiology and my own emotional base, then turns things on and off. So we can be at the watch of this and start to bring the science further in. So I call this the new integrated science of thriving, that obviously is the science of child development, integrates neurodevelopment and epigenetics and the science of resilience, family resilience, and so much more. That helps us, if we see it from this angle, manifesting this model, that we really are looking at trying to optimize very many untapped capacities that get lost when we only look and wait for disease and risk, and then try to address that without necessarily looking at the deeper causes. So we have a lot of possibilities, and I'm going to just share with you a little bit more about what I mean by a flourishing paradigm. So a positive construct of health really recognizes what the World Health Organization's definition of health is a state of complete physical, mental, and social well-being, and is not the absence of disease. And we know that many, many people and children and youth and ourselves as well may not have disease or illness or diagnoses, but we're not necessarily flourishing. And by the same token, many people have special healthcare needs. I know many children and families with special healthcare needs who are thriving, despite the fact that there's a lot of illness and diagnosis on board. So I think it's really important to think about it this way, that it's a dual continuum, and that by fostering the positive health construct, we can actually create the resources that allow us to deal with what's difficult and optimize the well-being in the face of the adversity or disease that we do have, and that seems to be a part of life. So there's some studies that go way back that look at death increasing for adults with similar levels of disease when they lack these qualities of flourishing, which I'm going to talk to you about in a second. And most adults in the United States during this study, which is a large sample of adults, that only 8 in 10 U.S. adults were really meeting these criteria for flourishing. And yet when they did, they were much less likely to die even with the similar disease and illness construct. So that's just something that to know that there's a body of research around that. And it was mostly on adults, so we were interested in helping expand this a little bit. What would flourishing mean for children? But the absence of flourishing was independent of factors known to be causally related to death. And it looks like my little thing broke down. And we see this a little bit. This is a New York Times article that talked about, went around trying to ask about what were some of the positive transformations that have happened in COVID-19. And this isn't to diminish what's difficult, but often what's positive is how things were handled when things were difficult. And that's certainly what our research shows in looking at positive childhood experiences, is it's how we're met when things are hard that ends up translating into some of the most positive experiences we've had, and bringing us back again to the fact that a flourishing story is a relationship story, and those safe, stable, nurturing relationships. And when we get disconnected from that in our own lives, we suffer. things that go haywire, both in our psyche and our identity and our happiness, but really actually neurobiologically and even in our microbiome, research is showing, and our brains get inflamed, when we don't find it. So some people were really honing in on how it brought them back to the basics of being with people and really prioritizing that, not just as a nice thing, but really a fundamental thing to well-being. And we've seen this too with some families who could look at the COVID-19 threat as pulling a thread of prior difficulties and using it as an opportunity to really go deeper to heal what's maybe not been addressed. Because every new trauma can pull the thread of an old one. And we need to be able to unearth what's been embodied in many ways. And if we don't, it can continue to knock around in our nervous systems and our identities in ways that can produce ill health over life. So I would want you guys to, I'm sorry to be so casual, you guys, everybody on this call, to just reflect on these qualities of flourishing for your own life and ask the question is, can you flourish amid adversity? Have you flourished amid adversity? Do you know anybody that does this? And are you? And so when we look at the different paradigms of flourishing, there's a synthesis that's been done on narrowing it down to the most common 6 attributes. And one would be having a sense of meaning in life, that life has meaning, that we're engaged in daily life, that we value and create positive relationships. And even though relationships are always moving creatures, if you will, that we learn the skills and value it and know how important it is to maintain and build and foster relationships. Notice and take in positive emotions that usually lurking in the middle of adversity are things to be grateful for, are things, and so you never separate them. They're both there, but trying to look at what is the wisdom of trauma and what are the things that we can do to have post-traumatic growth. And usually that's very possible in leaders in the country who've been in Harvard Business did a study on people who were the top leaders, and they've all had difficulties, but had this ability to recognize that and to try to leverage it. But this also means just recognizing the positive and taking it in. Oops, backwards. A sense of accomplishment, of investing yourself to learn something that either is really helping you express who you are or contributes to others, but some sense of mastery and achieving and just being in the process of that, not necessarily having to be perfect at all. And then finally, the sense of mattering, which is a back and forth piece of I matter, I feel I matter regardless of the work I do. I'm not just a transactional creature that has a sense of mattering because I do something for you, which a lot of people can feel really strongly. I know I add value, but they don't necessarily feel valued. And that's actually really common among service providers and a lot of doctors and social workers and teachers and even parents. And so there's science behind all of this, and I would love to go into it, but we're talking right now about what it might mean to flourish and that we set our sights in healthcare on producing well-being and flourishing. So I had a poll, but we're not going to do it because we can't put a poll up here, but I was going to do a poll and then show you how everybody, at least on this call, is doing. But I encourage you to do that because it's very interesting for people to come together and tap into how are we right now. So a conceptual framework we use to measure this for children, as you can imagine, was really hard because children are developing. They're not necessarily, having all those attributes. They're learning, right? Social emotional skills and identities are forming and learning what you like and all of that. So in the National Survey of Children's Health, it was a long process with Child Trends and myself and people from the AP and a lot of other experts looking at flourishing and how we might operationalize that for children so that we could try to get a bead on whether children were on the track toward flourishing as adults and flourishing in basic ways that parents could report on. A very complex thing, like how do you triangulate something's important? Can you measure it validly? And does it make sense? Can you measure it validly? And then can you do something with the data, which often can be hard if you measure things in a way where you only have really small respondents answering a certain thing. Your data doesn't. So it's a lot involved in measurement, and this was one of those cases. But we were looking at 4 different possible aspects of flourishing that are in the literature. The flourishing of the remembering self is where you look back on your life and up till now, how would you rate your life satisfaction? The flourishing of the experiencing self, which is right now, do you feel happy? How much have you enjoyed your life and felt positive emotions in the last week? Those are some of the questions that are asked. The flourishing of the requiring self. Do you have your basic needs met? Do you feel like you feel safe in your neighborhood and you have food and safety and social support? And that's a whole nother concept of well-being and flourishing. And then there's the flourishing of the living and relating self, which is the qualities that we can bring to life to as life goes on, we bring these qualities and are able to optimize our well-being in the midst of the lived experience that we have day by day, which is also through relationships. And that's what we ended up focusing on, is the flourishing of the living and relating self. If you took all four of these, that kind of makes up the bigger construct of what is well-being. And that's something we could talk all about, is how do you measure well-being? Because right now it's not being measured like by, national groups quite this way. They pick mostly the requiring self pieces, which, are good, but we're missing some of the other parts that are coming online now. So in the United States, after doing this, we were able to show that about 40% of children were meeting all three of the criteria that were identified, starting with like 100, and eventually we thought we'd get 9 items, and then it had to go down to 3 because of the real estate space on a national survey. But you do all these mathematical things in the back and psychometric analyses and item reduction. And so the 3 things really represent 3 different aspects of even the brain, if you will, on healthy development. One is being curious and interested in learning new things that you can observe in a child. The other is staying calm and in control when faced with a challenge, which you can also observe. Is there a real shutdown or acting out when normal day-to-day challenges happen? Or is there an ability to have all the emotions but not have it result in a real shutdown and or a big act out that's inconsistent with what it is that happened? And then the last was persistence and determination, that if a child picks a task, starts a task, they give up easily, or do they try to learn and persist and not just give up? So these are the 3 things we're talking about. And the variation across publicly and privately insured was not as big as you might think. So this is something that is more equal across income groups and can even be higher in some populations that we tend to think of as more marginalized, that they've learned more about, they have higher flourishing than even upper income or white families, let's say. So that's a really interesting thing when we're looking at positive health, how that looks. If we look at disease, we always know what we're going to see. But if we look at positive health and how different people and communities have risen up to optimize their well-being, we have a lot to celebrate. At the same time, we don't want to say, okay, you're resilient because you had to be, right? Otherwise you would have died. You had to go here. We don't want to have that either. We also want to do all the things we need to do to reduce the disease and the risk. So the flourishing paradigm is a healing paradigm because the problem is so big of adversity and risk. And I want to just say a couple things about that. So we know the United States is in the bottom third among 37 countries and really in the bottom couple on a lot of these indicators that are used internationally to look at child well-being. And we also know for adults, the diseases of despair have been on the rise, especially in America compared to other countries, as well as death rates. And the deaths are really coming from these diseases of despair that, are attached to drug and alcohol overdose, lung cancer, suicides, and chronic liver disease, and so on. I would say Delaware. I don't know if any of you are in Delaware, but I know the group is. You're in the upper top quartile, so there's something going on in Delaware. And of course, that doesn't mean there's not communities in Delaware where that is not true, but overall at a state level for adults, the well-being index was higher. And so I wanted to make sure I shared that with you because you're Delaware. But what's happening? Why is flourishing disrupted? If you think of flourishing as something that would happen naturally under conditions of nurturing and safety and getting your needs met, those 4 aspects of well-being I talked about, what disrupts it? And one of the main things, again, is we have 70 years of research linking well-being to safe, stable, nurturing relationships. For those of you who are new to this, it is not new. It's been around at least since the Mastery of Stress study in 1951 done at Harvard. And, Neurons to Neighborhood was in 2000. We are still trying to implement the science. So you have to have a long view and be very patient. I was not when I was in my early 20s. I thought by the time I was 26, we'd have universal. Everyone would have some way to have health insurance and all of our systems would be paid in ways that organized around positive health. But, obviously that didn't happen. So you're probably familiar with ACEs. And if you're not, you should become familiar with them. There are household level ACEs, and then there are things that happen in communities. So there's like adverse community experiences and adverse childhood experiences. And what makes them different really has to do with that early developmental attachment that is so, so profoundly connected to brain development, that we can really tolerate more adverse community experiences. Not that we should, but we can when we have a stronger family relationships and attachment. But those are interconnected because of the stress levels that happen. And this is, I'm not going to go over these, but I want to leave you with it in case there's somebody on here who doesn't know that this is a biological story. As much as anything, it can be explained when we have toxic stress, what it activates in the body and how it leads to not only all the symptoms of mental health that we have, which can be defined in many ways as being stuck on or stuck on off and having dysregulated nervous system, that then out pictures and behaviors and emotional experiences and so on, and pain. And there's studies for all of this, but to also know that this is all of us. So again, it's equally unequal, where if we have a lot of children in this country, about 21% with mental, emotional, behavioral problems. If they have 4 or more ACEs, it's more than double that. And it's very consistent across income groups once you have ACEs. Okay, once you have these adversities, which are more prevalent for lower income and are more prevalent for non-white populations. But once you have them, they're definite. That's why you can really see it has a lot of biological explanation that we need to deal with. And how do we do that? And that's where I'm going next. So flourishing by household income also, I can show you, flourishing is about 26, 27%, not statistically different between children in poverty and 400 or more once they have 2 or more ACEs. And we're talking 2 or more of the ACEs that we measure in the national survey. So it is equally unequal in many ways, which makes this a population issue and hopefully a policy issue. I am not going to go over this, but I want you to know we have a Delaware fact sheet in case you are in Delaware, where you can see whether you're talking about having a chronic condition or mental health issue, overweight, bullying or being bullied, mother's mental health, engagement in school, resilience and flourishing, or whether families stay hopeful when facing problems, which is a key aspect of family resilience, that it's much lower for those with ACEs. So we know this, and there's a lot of collective awareness now about the science, and especially about not ignoring the fact that you could take away all risk, because many children in the country do not have social risk and are not flourishing because of the absence of relational health. And that we cannot ignore this, even if we solve all our social problems. We have to address this as well, which is a more personal, kind of what I call we are the medicine issue. Restoring relatedness, restoring and healing our own nervous systems and our relationships so that we can live and breathe with nervous systems and minds and hearts that can take on life and grow with life in that flourishing way we talk about. So the Center for the Developing Mind, I think, has really got it right with three keys to this, of reducing the sources of stress, strengthening core life skills, and supporting responsive relationships. And I'm going to illustrate the use of the National Survey of Children's Health around this wheel of solutions. And I just want to make sure that because we started late, do I get to go late or not? Maybe tell me, because I did time this in a certain way, and I know
it's not a problem. You can
if I go okay. Yeah. If anybody in the chat goes no way, let me know, because then I'll just not go through some stuff, because I did time it for about 47 minutes or so. Okay, so I'm going to fly through this again because I'm making the points. Hopefully you're getting the points. You want to examine the data or the methods of the methodology. We'd have to talk more anyway. But basically, for reducing the sources of stress, the first thing I want to say is, well, what are the sources of stress that we have, and how do we know, what does the National Survey of Children's Health tell us about that? So we selected very high bar criteria, meaning no one could argue that if you have this level of risk, we know in the literature, multiple literature sources, evidence-based, these impact child physical, mental, social, emotional well-being, which then cascades into issues around school and friends and lifetime health, right? So food insufficiency, economic hardship, including difficulty paying for housing, transportation, unsafe neighborhoods and exposure to violence, treated or judged unfairly due to race and ethnicity. And then relational health risks we looked at separately because we hypothesized that they might be operating on a dual continuum as well. And we set a high bar of 2 or more ACEs, frequent parental aggravation, and poor or fair caregiver mental health, when we know good is also not good, because it was compared to excellent and very good. So usually good in one of those scales is there's problem. So we're being very conservative here, and then really low parental coping. And so what we find in the country, using the national survey, is about 56% of all U.S. children 0 to 17 have one or more of these risks, which we picked them because they don't have to be highly correlated. This is not a scale in that way. This is an index. So that's a methodologic question you might be interested in someday. What's the difference between a composite that's a scale, that's a latent variable, versus a index that purposely is trying to get different pieces of information that don't need to be correlated because they represent different categories of experience that have an impact. And that's a very important thing to think about if you're getting into measurement issues. So, and about 28% with any of these social health risks across the country right now, and 39.5. This is the most recent National Survey of Children's Health data. And for public insurance, it's about 73% have one or more of these risks, and 34% for private insurance, which is also very high. So we cannot ignore that there is a need and issues going on in all sectors. And for social health risks, it's about, I want to point out 0 to 5, because that's an important group, that it's about 25% for 0 to 5. So 1 in 4 young children, and 45 for public insurance, and about 37 to 51 across states. So those of you who are interested in policy, variation is information. When you see that kind of policy change in states and you adjust for all the demographics using multi-level modeling, you still see variation in states that can actually be exciting, because maybe there's something that's going on in policy. Maybe there's something going on in culture. Maybe there's something going on in practice. And understanding why we have such high variation across states, what are the things we can impact to reduce that variation, but also learn from the high and low and learn across states is very key. So we always look at that across state data, which the NSCH gives you the chance to do. For relational health risks, it's about almost 40%, 30% for 0 to 5, 55.5% for public insurance, and again, about a 21-point difference across U.S. states that have these experiences. Very interesting. We could just stop here and talk about what that might mean. But when you look at the prevalence of I just picked mental, emotional, behavioral conditions. I could pick any health issue, including asthma or anything, and it shows the same, because we've looked at it for all the 25 conditions assessed in the National Survey of Children's Health, that when you have no social health risk and no relational health risk, the mental, emotional, behavioral diagnosis rate is about 15.1. As soon as you have those 2 to 4 of those relational health risks, which often travel together, it's 42%. And when you have 2 or more of the social risks, like say economic hardship and food insecurity or unsafe neighborhoods, and we've looked at this in a way where it almost doesn't matter which you have. Again, it's that cumulative risk phenomenon. It's the number, it's the accumulation, it's the complexity, having both social and relational, that really ends up packing the punch. So it's 60%. So there are communities in every state in this country with children who are upwards of 60% with diagnosed, like a doctor ever told you your child had a mental, emotional, behavioral condition, which we could also stop here and talk about. And about 28% if it is 2 to 4 social but no relational. So you can see the difference between that 28 and 42, which is something we really hypothesize might be true and is true. So for the 60% of children with relational health risks that do not have social health risks, that's what it is. We need to pay attention there too. And that's an important thing. So strengthening life skills through any door, schools, healthcare, early care, workplaces, wherever we can, and strengthen resilience for children is really strengthening families and adults. We know that when we can build the qualities of resilience, which are built and trainable, they're not, there's maybe a small part of that that's trait you're born with, but for the most part, the literature is clear that we can actually really build skills for resilience amid adversity. And when we do, we see, they say 39.2% of children engaging in school with 2 or more ACEs versus 71.4. When you look at this across those social relational risk continuum, you see a similar slope, right? Slightly different level of school engagement along this bar from 66 to 80. It's 80 if you have neither, but even for those with neither of these types of risks, it goes down to 26% of school engagement if a child does not have this basic quality of self-regulation, which we know we can help foster. We have to keep fostering it, right? Like the weather, it can, you have to keep developing it. And then other studies are done on teaching a growth mindset. So I think we have a hard, easy cognitive bias where we have a lot of things that look soft. like teaching children recognition of emotions and emotion regulation, noticing instinct to behave and being able to take a breath and ask for help. These are skills that are trainable, that help build self-regulation. And then it becomes a habit that then creates a benign cycle of positive experience. Same thing with teaching a growth mindset. A lot of youth, including my nephew, who I've been talking to about this since he was born, poor guy, he's now 25, still has to be reminded he's not stuck. You know, we can grow and have a developmental orientation to life. And teaching a growth mindset in this randomized trial showed immediate reductions in depression for youth that stuck. That was done in Texas. So I kind of organized these different strategies that are evidence-based, and there's all kinds of literature that's hopefully emerging more and more when we can actually pin it down further in time-in practices of, you know, sort of emotion awareness, body awareness, restoring that if there's trauma, time with practices, feeling safe to connect, knowing how to connect, seeing people as a resource, seeing relationship as a resource rather than a threat, and time for practices, really recognizing that we often have the greatest joy when we have a sense of meaning and engagement and contribution to others, and really to just express ourselves and who we are. So these are very basic, and I put them in these sort of buckets with this kind of language just for purposes of presentation, but there are lots of literature behind each of these as well. So support nurturing relationships is the second big pillar. And again, through any door, and this is just saying that self-regulation skill, and this is from data from the National Survey, is really bumped up when there's parent-child connection, which can also be taught even amid ACEs. If we take what's hard and start talking about it in our families and in our communities, it creates a positive experience through the adversity that creates the feeling of belonging and connection that goes into a neurobiological cascade into our bodies and helps us start to heal through revealing, through connecting about what's hard. And so what we see here is when that happens, because parent-child connection in this case was measured by whether or not how well parents and children talk about things that really matter and share ideas. And when we look at that in cognitive testing, it means things that are hard, talking about things that are otherwise difficult to talk about. And when you can do that, it means there's enough trust. And when that happens, it's very regulating, and it helps to create self-regulation, which then cascades into the higher school engagement. And we've replicated this in a couple of other studies. Mostly this is just looking at family resilience and that parent-child connection across different levels of ACEs, so that even for those with 4 or more ACEs, it's a lower bump, but it's almost 3 times higher for children with 4 or more ACEs if we do teach family resilience and connection. And then we looked at adults reporting back on their childhood, just like ACEs. So ACEs has you look back on your childhood, and then we've mapped it, you know, at a population level, because you have to look at every individual individually, right? But at a population level, we know those adverse childhood experiences map and are consistently strong for predicting illness of every kind: physical, mental, social, relational. And so we looked at positive childhood experiences using some data, population-based data we were able to get a hold of in Wisconsin. And these are what they were: feeling able to talk to your family about feelings. Again, being able to talk about what's hard, and participating in community traditions, routines, rituals are so regulating and giving people a chance to participate. Feeling a sense of belonging in high school was even stronger than the feeling supported by friends. Some recent research came out about that feeling that I belong here, and making sure all children feel that they matter and they belong. And there's ways we can do that is critical, their ability to learn. And so we can do a lot organizationally. And this was what we found, that a 72% reduced odds of adult depression or poor mental health for adults looking back on their childhood who had more of those positive experiences at every level of the ACEs that they may have also experienced. And so there's a lot to unpack here and much more research that needs to be done. And I'd love to see if anybody here is interested, and maybe we can join together in that. So ultimately, the paradigm is you can have more adversity or less, more positive or less, and be less or more well. And that it really is the way these interact with each other that matters, that we can have high adversity and be relatively well, that we can have high adversity and it doesn't mean you're broken or doomed. And then by the same token, children with low adversity, say low on those social and relational pieces still might not be well if there's not the proactive promotion of protective factors at the community and family level and social level and school level. So I think this is just the paradigm that I want to leave you with, and hopefully by doing this have also brought you through some things about the data. And the last part of what I really want to highlight is that the flourishing paradigm is a relationship paradigm, ultimately. And to build the ecosystem, to take flourishing to scale is how I talk about it, has a number of points, but the key is changing our mental models. And I think we're getting there. We're starting to see at a societal level that we haven't had the mental models of equity, but we're building them. We haven't had the mental models of possibility. We've been stuck on disease and risk reduction and not necessarily fostering positive capacities as a way to turn toward what's hard and then be resourced to help, engage in healing and then maybe get the social will together to change the policies that we need to change. Because we have a society that very much operates in these silos, like we're all like sort of scared of each other. And so those are inevitably having to be dealt with, which requires skills. Relationships and connections, power dynamics have to then be met once we all agree we care about something. Okay, well, what are the relationships and power dynamics that are in place, that are keeping this in place? Because that's what's keeping it in place. And there's a lot of process work that has to happen and intelligence around community partnerships and what makes them work and what doesn't make them work and what are the qualities of the people engaged. So it becomes personal, not just a transactional mental exercise. And when we see success and transformation in communities, they're engaged in these issues. And then finally, you can then go toward the policies and practice and resource flows. We have a lot of information about what we could do and should do, and if we did it, what would happen. But we don't get there because we're not dealing with what's underneath that iceberg, if you will. So we have to deal with this, and we have a national agenda that's one thing you could read if you wanted to get a fast track on an agenda that was done that included many, many people across the country, including Dr. Patzer. Took us 4 years because that more people wanted to participate and we wanted to include. We had about 82 input processes. And to arrive at what now is just going to seem so simple to you, but we do unpack it into different policy actions and details in the paper and in the appendices. So if you want to really dive into this, I encourage you to read this. And it also led to 28 articles in academic pediatrics. So you can get a lot in that special journal issue if you want, because it's still really relevant. And in some ways, we put it together to bump the field's conversation up. But when I look back, say, Lee, on your article, it's more pertinent now than ever. Like we need to re-up and like re-disseminate all these things because they were from a lot of different sectors and people. But the bottom line is to educate and translate the science of human development everywhere at all levels. To cultivate the conditions for cross-sector collaboration, we have policies that really make it hard for schools and healthcare and child welfare to work together or what have you. And so we need to really, look at what's keeping us from doing things and not just go, oh, we can't because of that. But those are some of the micro policies we can start changing. And to adopt a launch and learn mindset. So in research, we often have hypotheses. We have this thing that works. We stick to it no matter what, and then we see if it worked. That's one model of research that works for a lot of things. I would say the kind of dynamic research questions we have around engagement and healing and how that can lead to social change is really more of a launch and learn, where funders and research grants start to fund in a more, you launch it in phase one, you learn, and then you can adapt. And if you don't do that, we're going to, I think, really not change very fast because you have to start somewhere and then start learning. And that has a lot of changes that need to happen in the way we do research and fund research and even IRB implications we could talk about. And then finally, all of this, never losing sight that it's really ultimately needs to restore and reward for safe, stable, and nurturing relationships and environments. And that ultimately will require self, family, and community-led prevention and healing, and building the capacity and the supports that allow that I can't, I can help, maybe start to help you rewire your brain, but ultimately if I'm wounded and you try to help regulate me, I have to do it. There's things I have to do myself. So we have this, and that same thing for communities. So this leads to many policy changes at the micro level. I call them micro policies that can happen often before we get big public policy. And there's a lot of research that needs to be done around whether we're talking about coverage and coding, cost and payment, contracting and accountability measures, capacity and training models, credentialing and integration so that we can get practitioners into hospitals that are needed but may not be able to be paid for. How do we handle all these issues are very where the rubber hits the road, right? And it plays out in healthcare, in hospitals, in primary care, in early care, in Head Start, in WIC, in home visiting. There's these dynamics that are driving human behavior that we want to marry the science to this and say, what are the things we can change and experiment with through research to see if we can create a context for transformation instead of, just having it be sort of a goal, but it's not really down to the basics, which really ends up being in these kinds of things. So the model that we talk about ultimately in that national agenda is we need population-based approaches, and therefore we need population-based data to continue on. We need integrated systems and services at the community level and research at that level as well. And then ultimately relationship-centered that, again, every colleague just said the other day, every success story is a relationship story, which I'm love. And multi-systems, private, public, across systems, and advocacy-oriented. Basically, if we're going to care about children and families, or even society at large at this point, we have to be good at taking what we know, taking the research we create, communicating it in ways that can be understood by people who are leaders and policymakers who need to know it's evidence-based, but need to understand what it means, so that every paper you ever do, everything you ever do is like, okay, what are my 10 slides I'm going to present to a person who could use this to actually make a difference in the world? And that really is challenging to do, I think, and we have to keep going. So this your being, their well-being is another key pillar of the ecosystem I've been talking about. But I want to take the last couple minutes to talk about this engagement and action piece, which really is everything you do and say creates an impact. This was a billboard in Richmond, California, where we did some work on this healing-centered trauma-informed care policy platform. And I just loved it because it's neurobiologically true that every interaction creates a reaction, including what we're experiencing right now. And also everyone, everywhere in interacting with children or another person is impacting that person, and that we underestimate our power and how much we really do impact each other by the way we hold our nonverbal communication, by what we say or don't say, whether we're creating a sense of mutual longing or belonging, and those implicit and unconscious biases that we all have. And so our being really matters, and that requires self-reflection and self-care. And, the success of any of these interventions really does depend on the interior condition of the interveners. And it gets even more important when you're talking about healthcare and really dealing with people who are suffering or who have illness. There's a very good book I refer you to called Compassionomics. A professor at Harvard put a lot of this together. And there's a huge amount of literature that doesn't get picked up on, right? Like you see a lot of literature and it's in the culture because of the mindsets, but there's a lot of other literature that doesn't come out. So I encourage you in your literature reviews to be very, very stealth, like really, really look, because you may think something has never been studied and you're going to find out that somebody did this awesome study on exactly what you want to do. And I'm constantly going, bless your heart. I can't even imagine what it took you to do that systematic review. But because you did that, I can do maybe this. So we see ourselves as a community of researchers. But this one study, for example, that was a study that was done well enough to make it into this Harvard synthesized book, is that just 40 seconds of compassion, like messages of empathy, kindness, and support with a patient, which seems like maybe an eternity when you're with them, really reduces anxiety. And think about why that might be important for a patient, because if you don't reduce anxiety, what happens to our ability to hear, learn, absorb information, ask questions, feel safe enough to really get it right before we leave and make sure we know how to use that medication or decide on whether to have that test or not if we just filter this through the medical model. It's very important. So, and some of the more recent studies on transforming care for, say, adults with complex needs who are very expensive in some CMMI, CMS supported research shows that this quality of presence and connection is actually what then launched the kinds of conversations that could happen that over time reduced the cost of care, hospitalizations, uptake of health behaviors, uptake of all of the resources we do link families and patients to, which are often not followed up on, and then we blame them, right? We have lots of lack of uptake of WIC, Head Start, home visiting, counseling, everything, where we do screen and find people, they don't go. And that's not because they're bad. It's because there's a lot of other things going on relationally and in our sense of capacity and agency that we need to attend to and feeling safe. And then there's other research that takes us all the way to the school, that it's not just doctor-patient, it's school. And of course, we know the parent-child, so everyone matters. And this is the teacher-child closeness study. So there's just some research out there that I encourage you to know about and look at if this is an area of interest to you. And we started in, I don't know, you were probably part of this in 1996 when the CAHMI got started. We started working on the top-down data, which is that population data, but also a bottom-up way of collecting data from families to be shared with their providers so that they could create a shared agenda. And so this cycle of engagement model and tools has been underway for a while. And I have all the research stuff that's at the end of the slides that I'm not going to show, but if you want it, I can share about the randomized trials and stuff like that. But the bottom line is that we created some family-facing tools so they can do pre-visit planning or make sure that all shared care plans for complex conditions are based on the context and the needs and the aspirations of the family and their whole system of what they rely on for care. So that's the care path for kids. So I'm going to just illustrate the early childhood cycle of engagement, and what we're looking for are a lot of research partners in this model of the cycle of engagement, which we've operationalized through these tools, but it can be operationalized using any set of tools that engage people, ideally before visits, to learn, reflect, not have to spend all the visit time filling out forms, where there's data exchange and an agenda that's shared, where you can really use that time to connect and refer to resources and make the warm handoffs and really get better uptake and holistic support, and then follow up with a post-visit assessment on a routine or every now and then basis to get feedback for yourself about the quality of care if you're, say, you're a pediatrician. And so we've tried to take this to the streets, and they're both aligned with lots of other performance measures. So, you know, if you do these, you should do better on the performance measures for payment. Linking this to payment is really key. That's where the policy piece comes back in for me. And, you know, you have to create materials. So anybody on this call is interested in dissemination and implementation research, or who is an expert doing it, bless your heart, it's hard. It's easier to come up with an idea, try it out in one little trial, and then go, okay, someone else will pick up on that. It's likely not to happen. Most research is not translated into practice, even when we try. And so we're really trying to translate into practice. And there's a science of dissemination and implementation research that has so much to do with communication and meeting people where they are and helping providers change when they're stressed. But right now, after all the decades we have spent trying to get kids screened, only about 30% are in the country. Most of those don't get follow-up. At about half of the young kids anyway, if you really look at it, are not getting all the recommended visits that are paid for by health insurance. So we have this huge opportunity to leverage what we have, and that's sort of why we focused on this population. So you have enabling policies. We have enabling payment structures in many ways. We have the requirements that we're supposed to do Bright Futures Care. At the end of this year, on December 28th, it's a law of the land that any health system is all I don't know what grandfathered in, but I'll tell you about what that means later, are meant to demonstrate by December 28th through the Public Health Service Act 2021, and if they receive any federal funding, that they're really meeting all of those criteria. And we know it's not happening. So how do we start to stay the course? And I feel a little crazy because I've been at this for 20 years, but hopefully it will pay off, but we can't do it without engaging families. That's the key. I was going to tell you a little bit more about the theory. So this is sort of a little bit what it would look like. You would send families to a website that you tailor. They would complete it. They get a visit guide. You get a clinical summary. You base the visit on that, and then you're able to get out of the way the screenings that you need, really focus in on addressing what to do about it, and get the resources and potentially do EHR. So anyone doing work right now, it's all about electronic records. Our findings are it's sometimes helpful and sometimes not to have things in the electronic record. And a lot of innovations are coming with external EMRs. Like if you do ASQ screening, it's an external EMR, and then you link it to your main one. And so I do want to just raise the issue of not being in this trance of everything has to be built in to the main EMR we have, and being really creative about how we can start to engage and get the family voice and community voice into the electronic record has been a lot of what we've been doing here too. So just to give you more visuals, won't go all over it, but the quality feedback that the Promoting Healthy Development Survey, which was NQF, and National Quality Forum endorsed in 2008, but long before that was being used, gives you feedback like after every 25 patients, let's say, you would get a report that would say, how am I doing on guidelines? Great for residency training and things like that. But this is actually, for me, done in a research context. Like, how can we start to do some hybrid implementation research where we're implementing while we're studying it so that we can start to learn how to really transform the health systems in the ways that we need to. The Care Path for Kids stands for this. It's connect, assess, respond, and engage, prioritize, articulate, translate, and honor. Which is a process of engagement that we've created with families. And again, just I'm not going to go into this much, but letting you know that if you're interested in doing research on shared care planning, caring for kids with more complex conditions or needs right now, this might be a tool that you'd be interested in. But for research, because I'm talking to you as a research group right now, we just created it. It needs lots of other people to come in and start thinking about, well, what are models that really engage families in shared care planning so we don't just have these plans that don't get implemented, and then again, we see the suffering and the rehospitalization rates that happen. So there's just a little here. And we always hear these good things from families. I have lots of reports back that families are not overwhelmed by using these resources, whether it's the well as a planner type thing or this. They want to be engaged. They're wondering why they haven't been before. They're wondering why you didn't ask them all those questions about ACEs and that kind of thing. But they have the opportunity to not answer it if they want. So it's very sensitive. People can or can't, and whatever they choose and feel comfortable with, they'll share with you. And finally, for those who saw all of the data I was working with, and I tried to highlight NSCH data on purpose here, you can go to childhealthdata.org. Like Lee said, we try to make it easy for you to just pick a year of the survey. We combine them. We'll be getting a 5-year combined data set in a little while. When the 2021 data comes in, it'll be 5 years, and then we can really go to town on all those state variation data because we'll have enough data by child subgroups at the state level to be able to understand why we have this huge variation. And maybe we're going to see improvements, say, in developmental screening. Guess where we see them? North Carolina and Oregon, that have done a lot at the policy level and at the practice level to improve developmental screening. It shows up in this data. So it's very exciting, and it's a wealth of research papers on everything from bullying to flourishing to maternal mental health to prenatal care, preterm birth and so on. So I really encourage you. And right now you can go and for grant writing if you want, get the up to the 3-way crosstab, actually get the micro data and see if you've got a good enough sample size to do something. Don't write a grant till you know you do. We really want you to do that. And then we help you learn about the data in friendly ways rather than have to read really complex materials. And we give you ready to use data sets. So if you were just to code the medical home data set or that family resilience data set or the child flourishing data set, believe me, wherever 2 or more variables come together, it is chaos. You have to deal with missing cases, system missing. What do I do with this? What do I do with that? What if it changed from year to year a little bit? The item, can I combine it? So we basically try to do all that for you. And leaving you with that resource. These are little flashes. Again, just flashes so that you know it's there for you. Where that you could see across state. And this is my last slide, which is really encouraging us to prioritize possibilities in everything that we do. Support each other in how hard it is to get systems change. But think about how far we've already come. This left-hand poster is from 1919 from the National Child Welfare Association, which was connected up to the Maternal Child Health Bureau when it was getting started, that basically really believed that no shock can mark an unborn baby, no horrible sight can deform him. And then went on to say, but worry, fear, and anger may affect his mother's blood, which supplies the food for the child. And so she should be calm, happy, and sweet-tempered. So this was public health for child development way back then, and we've come a long way. and we're in a perfect storm. And we have a lot going on legislatively to build the ecosystem. And I am excited for all of you as leaders in the field now and upcoming to carry forward those possibilities.
Well, Christy, thank you so much. That was pretty amazing. And this really is a paradigm shift, and it's taking a while, but I love the fact that this isn't just theoretical, but it's really based in data. And I really thank you for all that work that you've done over 20 years and will continue to do for hopefully 20 more years or more.
Yeah.
We may have time for one or two questions. I know it's late, but do we have any questions out there?
There was one.
Well, I always have a couple of questions, but you know, I'd
Yeah,
like
we
for
got one here.
everyone else.
Dr.
Okay.
Siegel?
Sorry, Claudine, go ahead if you want to.
No, you go ahead. You go ahead. You go
Okay.
ahead.
Well, fantastic talk. And to echo Lee's comments, you know, it was great science and great pragmatics, and I'm part of the choir that you're preaching to as a psychologist as well as a behavioral scientist. Here's something I struggle with. When you started to talk about linking some of the science to payment models to basically scale things and make them more possible, I get concerned, and I've seen this in many different examples of sort of the gamification of the metrics that we're using to get payment. So we're sort of bypassing the original intent just to sort of say we're doing the thing that we're supposed to say we're doing. So to use a non-healthcare example, I was thinking about a few years ago, I took my son to a Chuck E. Cheese, and I saw a sign on the wall that said, if you give us a 5 out of 5 star rating on our online app or whatever it is, we'll give you a $10 gift card, right? And so I see parallels. Yeah, I see parallels to that in healthcare, where we're trying to get a certain answer on a survey. We're documenting that we did something because that's where the payment models are now aligning. But it's not really the culture or the essence of the type of model that you're talking about. So there are these systems of care that work really well when the culture is there and the people buy into it. But when it starts to be imposed upon and people don't get all the support that they need, and it can look like it superficially that we're moving forward, but then we're not really actually getting the outcomes once you scale up that you did on the smaller scale. So this is probably an unfair question to ask you, but I'm sure you're giving thought to these things. Do you have any advice for us where we're trying to do in other areas the same kind of thing?
Yeah, I mean, first of all, I got started with some of this work at the Foundation for Accountability, which literally shut down when the National Quality Forum got started because our board and our funding all went there, and they were dealing with adults. So I took the CAHMI and kept it because they were going to deal with kids for 10 years, which they didn't. And so basically what we know are the measures that we've been measuring for 30 years now have not improved care. But we keep measuring them and using them, and attention is being paid to them rather than going into measures that are potentially more outcomes oriented, where you have more flexibility perhaps on how you get there, right? So we have person-centered outcomes oriented, which is what we're talking about, and trying to drive value-based purchasing to link up to new metrics and wrestle out the habit of using metrics that have already shown they're not driving improvement in outcomes, and certainly not if you take it to the distance of flourishing. Like, is this helping children be more ready for school engagement? So what you're seeing a lot of states do is say our metrics across sectors is school readiness, let's say, and engagement in school. Therefore, we have different systems that are playing a part in that have pieces of it, but we're coming in together to share accountability. And I didn't share with you our maternal and child health measurement compendium, which organizes all the measures being used across all these sectors and show how there's only like 3 they share. So breastfeeding is being measured in Head Start and in WIC and in, let's say pediatric practice or something like that, but it's in 3 different ways. And so they don't collaborate, right? Or maternal depression screening.
Right.
So I think that for me, this is where when I was 23, I thought by the time I was 26, we were going to get meaningful metrics to drive payment. And that's my MBA was about, financing reform hooked up with public health outcomes. And it's just so obvious we have to do that. And so for me, I think we really need to call the emperor has no clothes on a lot of the measures that we have, and that the providers have a lot more power. But then there has to be a willingness to come in and say, but we do want to be held accountable as a group for these things. And we will work together, and that there's lots of ways to make that a fair system. And we need to isolate those models and try them out in rapid cycle, like I talked about. And anybody who wants to work on that, I do think there's an appetite for it. I think there's health systems that are out there under global payments now who will be willing to really try to see what's going on. But so far with kids in particular, we're not seeing those models, but we see some for adults. And if we could model that. So I do think it's a lot of, but that's why the PHDS is something providers like, because they actually get feedback from their families. And you can do that at a population level in a CAPS-like way, because that's how we created it. But if you get your own feedback and you start to improve on your own, could you get credit for that? You know what I mean?
Mm-hmm.
Like the ABP, MOC requirements. Like if I'm doing quality improvement and showing some improvement, that's what should be, that my ability to recognize needs for change, do change, and see change, is that what we should be anchoring payment incentives to at this point, rather than some disembodied metric that may or may not work for you and that has never been shown to improve care. I have so much to say about this. I'm sorry I went on.
No, I appreciate it, but I appreciate the point on you need the right metrics.
That's all what it is. I mean,
Yeah.
it really is. And when we see, providers light up because they're getting data from their patients about things they know they can do something about, and it's scored very fairly, it creates action. And our research has shown it has improved care.
Thank you.
Mm-hmm.
So I have a couple of questions. Thank you so much for this really wonderful presentation. I learned so much. I'm not a pediatrician at all, so I'm not really familiar with all this. Although I know the ACE and all these issues. The well visit planner. Do you know how much it has been implemented already, and how?
Yeah, I mean, I had those slides in there in case anyone asked about it, but basically we've used it in, obviously the studies. So in clinics with about 26 doctors, and then in a trial with federally qualified health centers, a lot of Spanish-speaking population. And then it's had trials in Head Start, and there's been some use in WIC and home visiting. We did some work up in Philadelphia with Lori Wade on that. And then it's available actually as the public use site, because when the grant ended, the real tool actually links up to a dashboard that the doctor gets data, right? But I disconnected that and made it a public use site so families would just have the ability to use it on their own and bring their child visit guide to the doctor, email it through the patient portal or something like that. And that's where we've had a lot more use. So we have like about 30,000 cases, but we've done no advertising, no marketing. And every time we present it, it's a lot of interest. So that's kind of where we are right now. And we have a grant from the Robert Wood Johnson Foundation. And it's really what I'm curious about is engaging a lot more other people to, there's lots of grants out right now that I can't possibly apply for because I'm just a person and I'm people anyway, and I can't be 12, to try out IT-based methods to engage families to improve care. And so what happens is when we tell people about it, they want to use it, and then they have to engage in the implementation dissemination process. So that's kind of where we're at, but without doing anything, it's being used in the field across a lot of different health systems or systems of care, and then a lot more interest. So that we're looking for those partners in that community and family engagement research network to scale it. But this is this model was what, if you know Tamani Coker's work on the parent coach model, but it was basically the well visit planner, the PHDS, and then a personalized connected encounter. So it was, and we worked together on that, but she led it because it's always good to have somebody else do the randomized trial on something you created. But so we've had that, and so that's basically it. And then I have a lot of the research findings if you want to have them, anybody who wants.
Yeah, no, that's really
and protocols, like how do you do a baseline survey, follow up of the practice, post-visit surveys after you use it so that you can get feedback on how it went, focus group protocols. So if you want to do research in this area, we show that as well, just like the DOC.
Sounds great. That's fascinating.
It would have great utility in mental health visits.
Yeah.
As I'm sure you know, Christy, because the shared decision-making model in mental health is really behind well child care, and I think families are really seeking more information on how they can get their perspectives into mental health, because it's typically such an area that they really don't know where their role is.
No, absolutely. And to expect a response, like I was on a call just before this where we have added as an optional module that providers can add issues around experiences of racism. And a family was so grateful to be asked, but also so upset. She's really scared about her 12-year-old son, but no one's ever asked her about this, and it never came up. And it created a lot of opportunity in the railway for them to really be supportive. And it's something that's been hidden in her heart forever. But just by asking and giving the opportunity, then the provider felt safe to bring it up. And then all of a sudden they can start working, and they already have community stuff going on. But it's like we hide all these topics, but when you give families the ability to bring it up and drive it, it reduces stigma. And then you're answering their agenda. And over time, maybe 2-3 times doing the What Was It Planner, more and more will be shared. So we also show you as a clinician what wasn't answered. If something's not answered, that's actually not no information. If somebody skips an item, that's information. Why did I not answer that? And so families can skip anything they want, answer all of it. We have very few missing values, but when they miss something, usually it's because they don't want to talk about it with you because they don't feel safe. And that's a flag for you to build that trust. So anyway,
Fascinating.
it's so much fun.
I know, it's really fascinating.
But definitely people who want to do this, I'm trying to encourage other people to use these things for research, the model, the tools, whatever you want, adapt the concept of the cycle of engagement pretty much to everything, like you said. When we won a national award with the Office of the National Coordinator in 2012 for this, against like elderly people's apps and stuff. And they said, we need thousands of these. But then they went on to create them for adults. So we have very few people focusing on children and families and mental health. So I agree.
And how often is the NSCH survey
It's now every year. It used to be every 4 years. And it was every 4 years, and it was like 100,000 cases. And then we would, you could do a lot with it. It's now every year with lower samples. And so it's more limited in what you can do at the state level and the young child level. And of course, we encourage oversampling. There's oversampling for 3 to 5-year-olds to get the school readiness measure. And there's some oversampling for certain race ethnicity groups. States can oversample and buy an oversample. It's not that expensive, so you can get more data. But otherwise, it's every year, and we produce an every year data set. And then once we get the next one, we do rolling 2-year data sets. And then after we get more, but we also show you how to concatenate. You concatenate 4 years if you want yourself. There's a lot of issues if items change a tiny bit, which they tend to do, what you do with it, and then we try to do all that work for you. So it's every year with concatenated data sets for every 2 years, and then we'll soon be having a 5-year data set with 2021 with more COVID in it. And when I say we, it's the Maternal and Child Health Bureau, but I have an identity crisis because I feel like I've been so close to it that it's we, but it's really the Maternal and Child Health Bureau, and then we do, the work no one else wants to do to try to turn it into a data set. So you can just ride with it, because honestly, it's too hard to have to learn about the data set. That could be what ends up happening is the data set comes out, somebody writes a grant, they try to figure it out, 3 years later or 4 years later, a paper comes out, and they're so exhausted they don't even read it, which is true. Most people who write papers don't even read their own papers. Because they're so exhausted by the time it gets published. So we want rapid cycle within months of the data coming out in the government, getting it out so it can be used. And 2021 will be exciting. We can start doing some trends, right? And to see what happened with COVID.
Any other questions? I think
Hi.
Amanda.
Yes, I don't normally join these sessions, but I was really interested in your work on children and equity, so I popped in. I'm over at UD, and I'm a speech pathologist. I have a not very well articulated question about the intersection between language and mental health. Yeah. So we know that children who have difficulty communicating, for whatever reason, go on to have are much more likely to have mental health disorders diagnosed later on. I'm curious in a couple ways. One is, does your data set separate out language from, say, autism or other social pragmatic disorders? Yeah. And then on the other side, I'm also really curious about how the solutions that you're proposing serve children for whom talking therapy might not be the ideal way of delivering therapy because they don't talk well?
I mean, if you break down some of the mental health or treatments, many of them are somatic, many of them are experiential, and then some of them are cognitive, language based, and then often it's all free when you can get to it, because then you can really start to go to town, right? But if you don't have that piece, there's a lot of other research, and that's, I'm passionate about that. I think that the mind body practices, the somatic healing, and all of those things. So I would love to see a cohort of people come up with some ways we can measure more of those interventions, and also just do intervention research in general. It's not being done well right now or at a large enough scale. So for me, healing and helping children who have these issues, and looking at the range of interventions that certainly break from the tradition, because we have not, just like the NCQA measures, sorry to say, have not transformed pediatric quality of care. The interventions we've been using have also not necessarily gone upstream to prevent or even make children who have conditions thrive in the way that we know we could. So I am really looking for me, just personally, but yes, speech is separated out. It is actually considered one of the mental, emotional, behavioral developmental conditions. It's in the DSM-5, as you know, because of that link with mental health issues. But if it is, this is where there's no mind-body split. If it's physiological speech related, assuming there's plenty of language supports in the home, then, that becomes a physical thing that can become a mental health, dysfunctionally, putting aside the fact that physical problems can create brain inflammation that manifests as mental health problems. So there really literally is no mind-body split. But yes, it's separate. And I agree with you on looking at interventions, and that's a weakness in the national survey, I think, is the intervention side. But there can be follow-back surveys. If there was a way that there could get some sponsorship for a follow-back survey, they tend to go really well, where if you identify kids with certain conditions, like we did a follow-back survey on autism, it was an 85% response rate. That's the pathway survey, which we also make available, just like the NSCH. And it's so powerful. And so there is an opportunity with sponsorship to do follow-back surveys on the NSCH, or to take the survey itself and adapt it and use it in your own research.
And then let me ask one other question. In the data set that you've been collecting, are educational diagnoses also being included in that data set? Because
learning disabilities are in there, if that's what you mean.
Sort of. I guess what I mean is things that are coming through, say, the pediatrician's office may or may not be the same things that are showing up on the kid's IEP. Because in the US, those systems don't talk to each other, right?
Well,
so
that's
in the UK,
where
they talk to each other.
Okay, so there is a question on family experience with coordinating with the school, and whether they have a IEP or a 508 or anything. So there's information about whether you have those educational plans, and whether or not there has been coordination with the school and you rate that. Okay. And that's actually a very, very, very indicative measure, is how parents do that.
I'm sure it is. I'm sure it's super predictive because, well, for lots of reasons. But I just was curious how that was being collected, because I think that often these national surveys collect one side or the other. And
well, I think the NSH has done a really good job. I mean, the real estate space, like I said, is really expensive. We want more early childhood relational health oriented items and more positive health things. We can't measure as well for young kids as for youth. Parent-child connection is just really hard to measure for young kids outside of observational. So we're really needing to get, I think, a group that and we have the MRN Measurement Research Network that recommended that. So hopefully we can build on that. But yeah, there's lots of data there right now. And somebody like you, that's exactly who we're trying to help, because you're not going to go in there and figure all that. But you can go in and have confidence that the measures are constructed and used. It's easy to figure out how to do the analysis with a little bit of coaching from us, and then you can actually put it together.
Thank you so much.
But your data, your story.
Yeah.
Liberate data. And if we could do this for every federal data set and state data set, it just is beyond me why PRAMS isn't liberated. The RFSS could be liberated completely. And really, it's part of the congressional rule when they fund data collection to make sure it's available. But usually that means a flat file from the CDC. And it's getting better over there, too. But, yeah. And I've gotten so old, Lee, I didn't get to 20. It didn't all happen by the time I was 26.
Well, there's still time.
Right.
Well, Well, thank you again. And if we do have other questions, hopefully we can forward them to you, Christy. And we really appreciate it and appreciate your time and definitely appreciate the work.
Great,
great.
great. And just send me the link too, because I like to track all these if you want to. And I look forward to hearing back. And thank you for the invitation. Have a wonderful Juneteenth and weekend. And may you flourish.
Thank you so much.
I second that.
All right. Yeah. Okay.
Thank you.
Bye-bye. Bye.